Hey, Dr. Centeno, and thanks for joining me this morning. I've been gone for about 5 weeks, so just getting back and trying to get back into the groove of doing weekly Facebook Lives. Got a good topic this morning on PRP and damaged facet joints. And basically, same format as always, where I'll spend about 10 minutes going over this topic and then really spend the majority of the time trying to answer your questions about this topic or really any regenerative medicine topic. Hopefully we have enough people join us today because people sort of get used to me not being on air every single Sunday, and but we'll see. So today, the discussion is going to be about PRP and damaged facet joints. Again, same format as usual. I'll spend about 10 minutes going through all of this. And then after that, we'll answer your questions, whether it's about this topic, regenerative medicine, CCI, whatever you want to ask is fine with me. To ask a question, you put that question into the chat where you are. So if you're on YouTube, just put it in the comments in the chat. If you're on Facebook, same thing, just put it in the comments there. And then I'll see that here and answer your question. Regrettably, I usually can't get to all of these questions, even though I've got sort of a full hour dedicated. So the sooner you get your questions in, the better, because I'll answer them in the order in which I received them. So if you really want to make sure you get your question answered, please go ahead and start formulating questions now and get those into the comments where you are. Then I'll see them here and yours will get answered first if it comes in first, second if it comes in second. But obviously if it comes in 100th, then I may not get to your question at all, even within this hour. So we're going to talk today about, can PRP help damaged facet joints? And this is a topic simply because I've come across this a couple times in the Reddit group, this PICL or RPICL Reddit group that I run, where a lot of patients were asking, I don't really understand what PRP would do for a facet joint. Why would I want to get PRP into my facet joints, etc. So I thought I'd go into this in some detail today, and then obviously you can ask questions about anything else as well. So let me pull that up and we will start to get into that. So can PRP help damaged facet joints? So what is PRP or platelet-rich plasma? It's basically made by centrifuging whole blood, and this creates 3 different layers. So we've got the top layer here, which has usually just plasma. So it's sort of amber. And then depending on how hard you spin whole blood, you can end up with an intermediate layer below that that has some platelets, or if you do a really hard spin, all the platelets get pushed into that white band there called the buffy coat. And then on the bottom, you tend to get red blood cells. Now, there are different ways you can make PRP. You can add those red blood cells in. You can take those red blood cells out. Those red blood cells are also usually where some of the white blood cells live, with most of the white blood cells sort of surviving in that white band that we call the buffy coat. So that's what PRP is. So basically you take whole blood, you centrifuge it, you take off various fractions of that whole blood, and then you create the PRP, which has concentrated platelets and plasma with or without those red and white blood cells. Now, how does PRP work, or how do we think it works? Platelets contain alpha granules and exosomes, and those release growth factors and do other things that can orchestrate tissue repair. And that's really how we heal. So if you were to get, let's say, a paper cut, right, and you bleed into the cut, the first thing that happens, we know, is that it's going to clot at some point, right? It takes a couple of minutes, but eventually it'll clot. and you'll stop bleeding. And it's the platelets that form that clot. And that's what we mostly think of when we hear platelets. It has something to do with blood clotting. But what we don't really understand, or what most people don't understand, is those platelets are also releasing those growth factors to coordinate the repair response. So they've got that dual role of clotting, but also coordinating that repair response to heal that cut. So there are two main PRP types. Sorry, that should say two instead of TWP there. Leukocyte-Rich, which is where you keep those white blood cells in the mix. That's usually red because the white blood cells tend to come along with the red blood cells. And Leukocyte-Poor, where you sort of take those white blood cells out of the mix. You're also taking, therefore, the red blood cells out of the mix. And it's sort of this amber color. Now, what's the big difference between these two? Leukocyte-rich, or the red stuff, tends to be more pro-inflammatory. That means it's going to cause a bigger reaction in the patient when you inject it. The other thing that it's good at is that it tends to be more antibacterial because you have all of those white blood cells in there. Leukocyte-poor, or the amber PRP, is really more of the triathlete or all-around PRP in that it's used by most clinicians now for most things. And it doesn't provoke a huge inflammatory response. And that's why I think physicians like it. Leukocyte-Poor PRP, the amber stuff, is mostly used by physicians who are using high-dose PRP. The leukocyte-rich or red stuff tends to be less used, but really overperforms when it comes to fighting infection. PRP dose, basically in middle-aged or older patients, the higher the dose, the better the effect. Now, if you're 25 years old, you don't really have to worry about this. But if you're 45 years old or 55 years old or 40 years old or 60 years old, this becomes a very big deal. The research shows that the higher the dose, the better the clinical response. And how can you tell if you're getting high dose PRP? The simplest way to tell is how much blood they draw. You know, if you go in to get PRP and you give them your arm and they take 2 or 3 vials, you're not getting high dose PRP out of 2 or 3 vials. If they take 20 or 30 vials or some portion of a blood bag, you're probably going to get high dose PRP. So that's the easiest way to tell. Again, if you're going in and getting 2 or 3 vials of blood drawn as if you're getting a blood test done, you're not getting high dose PRP out of that. So just keep that in mind. So now let's go into what is a neck facet joint, right? Most people don't really understand that we have small joints in our neck, like the joints that we see in our fingers. And they're about that size on average. And there's 2 at each level. And those levels are named C0, C1, C1, 2, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7, etc. And there's a left and a right because there's 2. Now these facet joints help to provide stability, and they also allow a certain amount of motion in certain directions depending on that level. So they help provide stability. Now, these facet joints are, in fact, synovial joints. So they're not all that different than your knee joint or the joints in your fingers, meaning that they've got bone, they've got cartilage, they've got a fat pad in there, they've got a synovial covering, they've got a thicker joint capsule. So basically, they're set up like any other joint. They're just smaller and in your neck. And again, they're about the size of your finger joints. Now, the important thing for the upper neck facet joints, for those of you that have CCI and are watching, is that they have very specific referral patterns. So this is where the C0, C1 facet joint tends to send its pain. So if I were to piss off a 0-1 facet joint, you wouldn't really feel it in your neck, you'd feel it in your head, which is what you see here. Same thing with a 1-2 facet joint, which causes that kind of pain right back here at the base of the skull. And then a 2-3 facet joint, that's the referral pattern. Now, 2, 3, and 1, 2 are also important because they provide position sense. So if these joints are pissed off, you can get dizzy, lose your balance, etc., which makes them pretty unique among the neck facet joints. And it's one of the reasons why these joints become very important for many CCI patients, because they tend to be the generators of dizziness, imbalance, headaches, head pressure, etc. So is there data that PRP works? There's tons of data on PRP. In fact, every April or so, I put together this little infographic, and this is the one from this April, just a couple months old. So you see here about 180 randomized controlled trials on PRP. There is nothing in regenerative medicine at all that has this kind of research. There's not even a close second. And we don't have this amount of research for common drugs that we use, meaning there are fewer randomized controlled trials for amoxicillin. There are fewer randomized controlled trials for common blood pressure drugs. So we've got a lot of information that PRP works. This little infographic I put together here, each circle represents a randomized controlled trial. The green circles show superiority over the comparator. So let's say the comparator might be saline, for example. The circles that don't have any coloring in them means that the PRP was equal to the comparator. And then the red circles are the trial failures, usually associated with low-dose PRP. So lots of information here, right? PRP has been tested in knee osteoarthritis, knee meniscus tears, hand arthritis, hip arthritis, hip tendinopathy, various types of shoulder issues, carpal tunnel syndrome, epicondylitis, which is tennis elbow, golfer's elbow, in the low back, SI joints, Achilles tendon, ankle arthritis, and plantar fasciitis. So as you can see, we have lots and lots of information that PRP is effective. And this is just knee OA. And you can see here, if we really dive deeply into the knee arthritis category, into that category, we know that PRP is better in general than hyaluronic acid, which are the knee gel shots. We know that it's better than saline. We know that it's better than steroid. We know that it's better than physical therapy. We know that it's better than surgery. We know, high versus low dose, multiple injections versus single injections, if you activate it, don't activate it, etc. Now, I bring up knee osteoarthritis because, again, remember, at the end of the day, facet joints are just little joints. And so if it works in knee osteoarthritis or hand arthritis, it's going to work in facet joint issues as well. And these are the studies in the low back and SI joint, which is the part of the spine that has the most PRP literature published. So can PRP protect cartilage? This is a thing I did a couple of years ago on the research at that time, showing that we had 4 studies that looked at cartilage protection. These were randomized controlled trials with PRP that were positive. All of those studies used higher dose PRP. As we got to lower dose PRP, really below the definition of PRP, you started to see negative studies for that. So the answer is probably yes, based on the information that we have to date. There's cartilage in those facet joints, so that's helpful. But it depends on the dose. You have to get high dose PRP. So in summary, the data supporting that PRP helps joint arthritis is now pretty darn mature. Facet joints are like the small joints of your hands or other joints in your body. There's nothing special about a facet joint. And these can be helped by PRP injection based on the literature and based on my clinical experience. And we probably are seeing some cartilage protection effect, especially as we get to the higher doses of PRP. Okay, so that is, I'm done with that. Let's try to expand this here, and I'll start getting into answering some questions here. Alexis, how does the strength of Progenics PRP compare to that of a local doc doing PRP? Yeah, Regenix really uses high dose PRP and tends to use very high dose PRP. So at the end of the day, I don't know any specific local doc, but in general, Regenix is going to use higher dose PRP than most of the docs in that community based on my experience of what I see. Next one here. Is it common for headaches, muscle flare-up pain to come and go with CCI? Pretty common. Oftentimes in CCI patients, that's based on activity. So what do I mean by that? If you're unstable and you're moving around more, that joint that causes the headache, let's say it's C1-2, that causes pain right at the back of the skull base there, that joint is going to get more beat up. Then it's going to complain more, and that's going to cause more headache pain right at the base of the skull there. Lana, I have severe arthritis in my shoulder with bone on bone, I am high risk for reverse replacement. Will PRP help? Yeah, Lana, for severe arthritis, if it's going to be helped, it's usually going to be helped by more bone marrow concentrate with PRP, and that's probably going to require an injection of that into the joint, into the bone as well, and into the rotator cuff in my experience. So the answer is PRP is probably not the best match for that type of issue, but there are other things that are better matches. M. Purple, welcome back, Dr. C. Do you see patients regressing after 2 PICLs, or do they plateau? Say if they needed 3 and only got 2. Yeah, so in general, we had this natural experiment, I think I've said a couple of times now during COVID, where we had patients who couldn't make it back for whatever reason, let's say for a year or 2. And we had other patients, about half of our patients, that had a little hiatus of, let's say, 3 or 4 months when COVID was really bad, but they made every effort to get back in and stay on schedule with their PICLs. About half those patients regressed, about half those patients didn't regress. So I would say it's 50-50 based on my clinical experience answering your question. Nathan, what type of imaging is typically best for finding instability in the thoracic spine and ribs? You know, Nathan, there isn't great imaging for finding instability in the thoracic spine and ribs. DMX is really not going to work well there. That's usually going to be a clinical exam. Now, there are times you can use ultrasound for the ribs. And it's reasonably accurate, but very qualitative, meaning it's sort of how it looks to the doctor rather than measuring specific metrics and comparing against normal or abnormal measurements. So instability in the thoracic spine and ribs is usually not best quantified on imaging. That's more of a clinical exam finding. When you go into the doctor, they do a complete physical exam, history, etc., and then make that diagnosis and treat it. Stephen, can Regenix network outside of CSC treat occipital neuralgia? Yeah, I would think pretty reliably. You're still going to have to check to make sure that that specific doctor is comfortable treating occipital neuralgia, but I would say most of the doctors doing cervical spine work within the Regenix network are going to be comfortable treating occipital neuralgia and doing hydrodissection of the greater or lesser occipital nerves under ultrasound. Stephen, does CSC offer something to calm the patient before or after PICL if necessary? We do PICLs under full anesthesia. So that means the person is sleeping. It's IV anesthesia. So that obviously takes the calming the patient part out. Now, there are times, for instance, before the PICL where we may have to give the patient some Valium-like drugs IV or Versed to make sure that they're calm before the procedure, but anesthesia sort of removes that component that you might see if no anesthesia was being used. Vera, hello, Dr. C. What is the rationale for injecting around a torn disc versus inside? How does it help? Yeah, Vera, I think what you're talking about is the difference between a functional spinal unit approach versus an intradiscal approach. A functional spinal unit approach means that we are injecting around the disc in lots of different structures, into those facet joints, into the ligaments, damaged muscles, etc. And we're trying to calm down various things, the spinal nerve there, the facet joints, etc., while we're providing more stability through tightening ligaments versus just injecting the disc itself. The reason not to inject the disc itself is that it adds substantial risk over that functional spinal unit approach. Now, there are times that you do have to inject the disc, and that is something that we can do, but I always explain that to the patient, that there's about a 1 in, let's say, 500 to 1 in 1,200 chance that we're going to need to treat that disc for discitis if we inject the disc. And some people would say that that chance is as low as 1 in 200. Some people would say it's about 1 in 1,200. So let's say 1 in 200 just to be conservative. And that requires IV antibiotics and possible surgery. So when I have that discussion with patients on, do you want to inject the disc or not, then most patients choose not to. But as long as you understand that, we can always inject the disc as well. Maria, would near-infrared light therapy help reduce muscle pain caused by CCI? Would also help a flare-up after EPICL. There's no reason not to use infrared light treatments after PICL. The only thing I can think of is sometimes it'll stoke some inflammation. And for some patients, it might stoke too much inflammation. As far as would it reduce muscle pain caused by CCI, I haven't necessarily seen that or observed it. Will it help a flare-up after EPICL? Again, I haven't seen that or observed that. Purple 3000, what is the typical bone marrow replenishment timeline? Is it slower for middle-aged women? Yeah, if you look at the doubling time for mesenchymal stem cells in culture, usually the doubling time is at most a couple of days. So how long does it take to replenish bone marrow in the average person? Not that long. If you just look at how quickly the existing stem cells left in there could double and replace themselves. Now, we usually give, because that's a very, very conservative estimate, and that's sort of consistent with blood donation guidelines, but it probably occurs much more quickly than that based on what we know about mesenchymal stem cell and other stem cell doubling times when we have those cells in culture. And presumably culture is not as good as growing those cells as your own body. Nikki, how do you know if you have damaged facet joints? Can you see that on an MRI? Yeah, you can kind of see it on an MRI, meaning what you tend to see more on an MRI is an enlarged or arthritic facet joint. Usually, if they're damaged, it's a combination of clinical history, i.e., where is the pain, and also a physical exam that palpates each and every facet joint in the neck. And that's an important thing to realize, that if you're seeing a doctor who is going to try to determine if those facet joints are causing pain, and as a result of that, which ones should we target, it really takes an exam where you're lying face up on a table. The doctor has his hands on the back of the neck. They're palpating every single one, 0, 1, 1, 2, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7, all the way down, and recording which of those is tender, and then matching that with the referral symptoms that that person has to target specific joints. However, if you go in and see a doctor and they don't do that with you lying face up where the muscles are all relaxed, but instead they just quickly touch back here, they're not really targeting facet joints, and you should probably find another doctor. Vero, is it considered too much to do PICL, low neck, and low back at the same time? Not for most of our patients, no, Vero. For most of our patients, I would say that that's pretty typical, that we treat the upper neck and lower neck. And I would say 1/3 to 1/2 of the time, we're also treating something in the low back. So that would be pretty typical or more common than less common. Now, the caveat there is that if you have central sensitization, then we'll do the less is more, and we won't treat all of those areas. And that's maybe 1 in 10 of our patients. Stephen, is hair at the base of the skull ever an issue for injections such as 0.1 or 1.2? No, Stephen, not for fluoroscopy, because fluoroscopy is not sensitive to things like that. Now, if you're going to try to do those injections with ultrasound, which is below the standard of care in my medical opinion, then the hair in that area could be a problem because it might reduce that ultrasound signal. But it's not a problem for CRM fluoroscopy with contrast, which is how these injections should be done. Maria, how would you compare a flare-up after an EPICL to a shockwave therapy session? I would say that EPICL flares would be more than after a shockwave therapy session for most patients. Having said that, I can't say that I've compared a lot of reactions to both in my CCI patients, meaning, patients usually don't come in and tell me, hey, I had a 6-day flare with shockwave. They might say they had shockwave, it worked or it didn't work, but they're usually not providing that level of detail. So I may have limited information to base an answer to that question on. Robert, is there data that HRT can increase stem cell count? No, Robert, we ran that experiment, oh God, more than 10 years ago. I think I've described this previously in some of my other comments, so you may want to go back and look at those answers. But basically, we tested this. We didn't see, for example, that testosterone had any effect on stem cell count or any effect on improving that person's stem cells, even though that's still a common claim. It was a common claim back then. It's a common claim now. Our research didn't bear that out. And we did really extensive research on this because I really had a belief that it would, or it should, because everyone was just saying that that's what you should do. But when we tested it, we couldn't verify that that was the case. Taylor, good morning, Dr. Centeno. With my first EPICL this Thursday, I was expected to be a flare or flared up. I'm doing better than pre-PICL. I believe this is called the honeymoon phase. Your experience, how long does this last? Yeah, Taylor, usually a honeymoon phase can last for 1 to 2 weeks, sometimes a little longer. But that's great to hear that you didn't get the huge flare up, because obviously that's a better place to be than getting a huge flare up and then having to sort of interpret your symptoms through that flare up and try to figure out how to get to the other side. So sounds like you're doing pretty well. Nathan, what is typically needed to determine if the jaw needs to be treated? Do CCI patients sometimes have a popping situation on one side of the jaw? Yeah, Nathan, usually we're treating the jaw when the jaw is causing some functional disability. So what does functional disability mean? Functional disability with the jaw means that a person is having a hard time talking, a person is having a hard time chewing or eating, and as a result, they're making changes to what they do to avoid using their jaw. So that's usually when we add in treatment of the jaw in our CCI patients. Hey, do me a favor, if you could do a like, comment, share, subscribe here. Obviously, you're commenting, so that's great, but if you could do a like and subscribe, that helps YouTube help other CCI patients find this content. So if you can do that, and if you are enjoying having a doctor spending a Sunday answer your questions, that would be much appreciated. How does CFC handle a patient that's extremely flared neurologically post-PICL? I don't necessarily know what you mean by extremely flared neurologically, meaning a lot of CCI patients put things into the neurologic category that I wouldn't put into that category. But if you are asking how do we handle a patient who is very, very flared up in general prior to, usually it results in that less is more type treatment. So what that means is that we're going to do a smaller, less invasive procedure out of the gate. And as a result of that, we're going to try to manage the post-procedural flare-up. So that's usually how that works if someone's coming in very, very flared up. Alexis, how might COVID affect the facet joints? Alexis, at this point, we don't really have any data at all on how COVID would affect the facet joint, so can't really tell you there. Stephen, does occipital neuralgia and dead traps, shoulders aligned with CCI type 2B? We can certainly see CCI type 2B patients who have occipital neuralgia and problems in their traps, but it's not pathognomonic, meaning it's not specific for CCI type 2B. In order to get and determine CCI types, we do that with movement-based imaging. If you already have a CCI type 2B diagnosis, then those are common symptoms in those patients, but they're also common symptoms with other CCI types. Is gasping for breath as you're trying to fall asleep a symptom related to the vagus nerve? Usually that's related to obstructive sleep apnea. Obstructive sleep apnea is fairly common these days. It's related to weight. So adding weight can make it worse. In addition to that, it can be related to forward head position, decompensated posture, etc. So I would say usually not a vagus nerve issue. Now it could potentially be a phrenic nerve issue. It could potentially be a scalene muscle issue because scalene muscles are accessory muscles of respiration, but most commonly it's obstructive sleep apnea. Jess, I think I answered that one above. So the answer to that one is yes. Stephen, your thoughts on concentrated breathing exercises and diaphragm breathing for CCI patients and their symptoms? I think what you're focusing on here is trying to reduce the reliance on the accessory muscles of respiration like scalenes and instead focus on breathing through the diaphragm. I think that's great. Is it going to fix CCI? No, but certainly anytime we can offload some of the muscles that might be used or abused in CCI patients, like the scalenes, I think that's good. Does being on a GLP-1 cause issues for having a PICL? Any thoughts on new fat of microdosing GLP-1 for inflammation? Well, GLP-1s can help with inflammation. I think the data that's coming out on that's pretty compelling. And as far as being on a GLP-1 and losing weight, that's a good thing for this type of problem for CCI. As far as microdosing GLP-1, I think that's more of a fad. I don't think we have any clue that microdosing GLP-1s does much. So listen, GLP-1s I think are a net positive. Now, something that you need to pay attention to if you're on a GLP-1, and if you're going to have anesthesia of any type, whether it's for this procedure, the EPICL procedure, or for any surgical procedure or any procedure where anesthesia is used, you have to be careful to be off of it if you're going in for anesthesia, because the problem is it slows down your gut and can dramatically increase reflux while you're asleep. So you can actually aspirate much more easily if you're still on the GLP-1. So there are common surgical recommendations. Usually it's off for a week prior, but you may want to research that and ask the anesthesiologist or the doctor that's doing the procedure what their specific protocol is. Has the doctor heard any interesting or positive stories from patients about the beneficial effects? BPC 157, TB 500 in the area of ligament injuries. Yeah, I mean, right now we know almost nothing about how BPC 157 or TB 500 impacts ligaments. So I would say no. Now, we certainly have patients that make the decision to take those things. Are they working, not working? I couldn't tell you. We have some patients that claim they get some relief, which is great. The biggest concern I would have is that we have no control over what patients are receiving when they order something like BPC 157. So it's kind of the Wild West out there when it comes to those sorts of things. Vera, when do you see platelet-rich versus poor platelet? I mean, for what? Yeah, Vera, so for example, platelet-poor plasma is usually used in muscle injury. Why is it usually used in muscle injury? Because it's been shown to activate muscle stem cells in vitro better than platelet-rich plasma. Platelet-rich plasma, on the other hand, has been shown to be far superior in joints. So that's a good example of where we might use both, but we'll make both so that we'll have both available to us on the treatment side. Afro. Is neck crepitus at the base of skull caused by CCI? It can be caused by CCI, yes. So crepitus is popping and cracking. So this patient is asking about popping and cracking the base of the skull. Oftentimes, in my experience, that's due to instability at C1, C2, but it could also be to just arthritis at C1, C2 as well, because arthritic joints tend to pop and crack more than the normal joints. Kelly, can CCI cause jaw clonus? My neuro found it an appointment I had a few days ago, and instead is going towards neuromuscular disease. Instead of considering my EDS and horribly arthritic upper 3 vertebra as unstable, I choose CCI over ALS. I've also had a normal EMG study and normal neurofilament biomarker lab. It's possible that CCI could be related to jaw clonus. Other things can cause jaw clonus as well. As I usually would comment, it's important to rule in or out CCI with movement-based imaging. So the next step would be movement-based imaging to see if it's even on the list of things you should consider. Alexis, is there a connection between painful facet joints and cervical muscle stability? Yeah, Alexis, it's certainly been considered by Elliott et al. Jim Elliott is one of our old physical therapists that is now a college professor working on research in multifidus atrophy and has published much of the literature there now, certainly in the neck. And one of the mechanisms that's considered is that the joint gets injured, and as a result, the body tries to shut down movement at that segment, which then causes the atrophy. So there may be a link. I don't think anyone knows for sure, but that is something that has been talked about as a possible cause in some patients. D.W. Smith may have missed the definition. How does a provider achieve high dose PRP versus low dose? Yeah, so the first thing that you have to do as the provider to get to high dose PRP is to take a ton of blood. So for example, as I said before, rather than 2 or 3 vials of blood, like you might see in a blood test, 20 or 30 vials, or a blood bag, or some fraction, half a blood bag, etc. The next thing you have to do is to have a system, whether it's being processed in the lab or processed through a kit, that can take a high input of blood and produce concentrated PRP. So both of those two things have to happen, a high blood input and a process that will produce high dose PRP, meaning take the platelets in that large blood volume and shrink that volume down to a much smaller volume. Stephen, what specific part of the C-spine can cause muscle guarding and traps in sternocleidomastoid? It's usually on the sternocleidomastoid side, C1, C2. Now, muscle guarding in the traps is more common for other areas of the neck as well, but sternocleidomastoid is usually specific more for C1, C2 in my clinical experience. Jess, if your core is weak, do you recommend PRP in those areas first and shoulders before PRP in the neck to help stabilize the neck? Yeah, I think the first thing to start with, if your core is weak, is to strengthen your core. So that's going to be more physical therapy. And then whether or not you get PRP in your shoulders or in your neck is going to depend on what the diagnosis is. So for example, if we're talking about the neck and you have an injured facet joint in the neck, and you do physical therapy and that doesn't help, then PRP injection into the facet joint would be a reasonable next step, but you would want to fail conservative care, i.e. physical therapy first. D07, what would cause you to consider the need to add stem cells to upper cervical facet joint versus PRP? Is PRP only or PRP with stem cells more superior to the other? Yeah, so bone marrow concentrate, or stem cells as you're describing it there, which is what I think you're talking about, is much more pro-inflammatory, and most patients have a hard time tolerating it. So we start with Leukocyte-Poor PRP that's high dose. Now, it's certainly possible that we get into the situation where we have a patient who can tolerate that very easily, has very little flare-up, and we can move to bone marrow concentrate from PRP because in general, bone marrow concentrate carries a bigger punch, and that's usually bone marrow concentrate plus PRP. But that's on a case-by-case basis because of how pro-inflammatory bone marrow concentrate can be. Having said that, it's important to note that when we're injecting the upper cervical ligaments from the front, it's not uncommon for us to get bone marrow concentrate into things like commonly the C1, C2 facet joints. And so many patients are getting a C1, C2 facet bone marrow concentrate plus PRP injection just by the very nature of the EPICL procedure. M Purple, how long does it take for PRP to heal or reduce pain in facets? Is the benefit permanent? Yeah, so it's going to work just like other joints. So at the end of the day, for example, in a knee joint, I use PRP in my knees. And I can tell you from personal experience, for me, I've got a fairly normal inflammatory matrix. So I'm not like some of the CCI patients that are hyperinflammatory. But for me, I'll usually get swelling in the joint for a couple of days. I'll play through. I'll continue to do what I normally do or can do during that time. And then at the end of the day, what will occur is that I'll start to feel better in the joint along the first couple of weeks. So that's for most patients what's going to happen. Among all patients treated with PICL at the Centeno Schultz Clinic, maybe, what is the greatest number of PICL procedures that a single patient has undergone? Yeah, I would say, I think I've answered this a number of different times. So most patients are going to be 2 to 4. We'll have some patients, it's all a bell curve, right? A bell curve is that thing that looks like a bell. And most patients are in the middle of the bell curve, and then you have people on either end. So in the middle of the bell curve is 2 to 4 PICL procedures. Then we've got people on one end of the bell curve that are less, they're one and done. And we've got people on the other tail of the bell curve that are more. So then we'll get into far fewer patients that get 5 procedures, far fewer patients than that get 6. I think the most I've ever done is 7. I'd have to double check that, but something like that. But again, that's going to be at the very end of that tail. Jess, have you done PICL procedure on a patient who been floxed by fluoroquinolone with no issues? Yes, we have treated patients who ascribe their issues and the start of their problems to fluoroquinolones. It's not our biggest category. I would say our biggest category is probably hypermobile patients with or without MCAS. But we have done, I don't know, I can only speak for myself here. In my patient population, I have at least 20 or 30 of those patients who say they've been floxed. How often do you usually treat occipital neuralgia before you become pain-free? More than 4 times. Well, that really depends on what's causing the occipital neuralgia, right? Occipital neuralgia isn't really a diagnosis by itself, as it is a description of a problem. So the problem that's being described is the occipital nerve is pissed off. Then you have to get to pissed off by what? So for the most part, there's usually something causing occipital neuralgia. So in our patient population, that would be upper cervical instability. So you would have to treat the upper cervical instability and the occipital neuralgia at the same time. And then that would go with the number of PICL procedures, what we were talking about before. As far as if we were just treating the occipital neuralgia and we didn't know what was causing the occipital nerve, the results are going to be hit or miss. You need to know what's causing the occipital nerve to have those problems. Sometimes it can be postural, so you have to fix that posture and treat the occipital nerve, in which case you might treat it once or twice. But if you're repetitively treating the occipital nerve and not controlling for what's causing the problem, you're really not doing a good job as a medical provider. Is it possible for CCI to cause instability-related problems in the upper thoracic spine? If so, what's the mechanism behind it? Not usually, no. Now, we certainly see patients that have thoracic problems and upper cervical problems and CCI issues, but it's usually not the case that CCI causes thoracic instability. Can you take extra stem cells at the first EPICL and store them for the next? We can't. That's not legal to do in the US, so that's not possible to do. Do adipose-derived stem cells, really MFAT, combined with PRP offer greater ligament regenerative potential than bone marrow concentrate? No, there'd be far less published information on how MFAT impacts ligaments. There's much more information on how bone marrow concentrate works there. So as a result, we wouldn't use MFAT in ligaments simply because there's very little published literature that MFAT helps ligaments, whereas there's more published literature that bone marrow concentrate helps ligaments. How long before an EPICL do I have to stop taking Acroxia? Is amitriptyline okay to take during EPICL? Amitriptyline is not a problem to take during EPICL. Acroxia sounds like that's not a US drug. Looks like a UK drug, but it's a non-steroidal anti-inflammatory drug. So an NSAID, so you want to stop NSAIDs a good week at least before an EPICL, and then you wouldn't want to restart it for at least a couple of weeks, preferably a couple of months. Afro, does necropathy come from CCI? Yes, CCI patients often report neck crepitus, but again, as I think I said before, neck crepitus or cracking can happen for lots of reasons. Another common one would be arthritis in the joint. RE flare-ups, are there prerequisite methods for those hypersensitive nervous system to regulate it? I'm not quite sure the question there, Robert, but at the end of the day, we try to deal with that less is more approach. There are times, like I just did this week, where I had a patient that needed to be prescribed Lyrica as a nerve pain medicine to try to see if we could help that person through a prolonged flare-up. And this was a person who had the less is more and still had a prolonged flare-up, whose sensitivity or central sensitization was so bad that she couldn't even tolerate washing. So lots of different layers of issues there. But those would be the two things that come to mind. And purple, how many PICL would typically take for a 3.5 millimeter translation at C2-3? It depends on what you're talking about. So if you're talking about a forward translation, ePICL typically wouldn't be used. If you're talking about a backwards translation or type 3B, as you write here, as far as getting rid of that backward translation, in my experience, 1 or 2. But that doesn't necessarily translate to the number of procedures needed, because the number of procedures needed is going to be more focused on how much damage has been done. So for example, you could have 2 patients with the identical amount of 3.5 millimeters of translation backwards of 2 on 3. One has had very little damage to the 2-3 facet joint. They might only need 1 or 2 treatments. The other one has had substantial damage to the 2-3 facet joint. They might need 5 or 6 treatments. Doctor, how does maybe getting a root canal redone impact ePICL healing? Yeah, the biggest problem there is going to be positioning of the head or neck. And I've got a whole video on that. If you go to the channel, my YouTube channel, which looks like you're on YouTube, go to my channel and just type in surgery and search my channel. And you'll see, I think it's the first video that comes up with that keyword that talks about head or neck surgery in CCI patients. And it'll go through the kind of things you need to try to do to protect yourself, because the biggest concern is that when you're getting anything done on the head or neck, the surgeon or the dentist is going to position your head how they need to position it to get a maximum view of the parts and pieces they need to see. They're really not going to be thinking in their head, this person might have ligament damage in their upper neck, and how do I mitigate that? So I've got strategies for patients in trying to deal with the surgeon's office and the surgical team to try to make sure that they understand that they have to balance their ability to get the right view of what it is they need to see with the fact that the person's got a neck injury. I tend to have patients run through a spiritual, physical, emotional, and physical investigation to help regulate, treat, or calm the nervous system. Many I met are stimulants by single bond prescript. Yeah, Robert, I think what you're talking about is something that's become common and I think is helpful in the CCI population. And that is really working with patients on not overreacting to everything. And overreacting to life, the universe, and everything. And what I tend to see is that approaches like this, where you try to neuro-linguistically reprogram somebody to be less reactive to everything, including stimuli, is helpful. Basically, taking someone from focusing on disability to ability through that approach. So I would agree with you that that's a helpful way to look at these issues, and it would be helpful for many CCI patients because they tend to overreact to life, the universe, and everything, including small amounts of stimuli. Now, having said that, there's a portion of that that's perception, and there's a portion of that that's neurologic that isn't really going to be impacted as much by approaches like this. Ashley, hello, Dr. C. I had ePICL in April. Some people in the group have recommended me seeking AO because apparently if you aren't in alignment and your ligaments are tightening, they will tighten in the wrong place because your neck isn't aligned right. I think you have recommended not to seek AO after ePICL if we've ever been forced. Is true. Yeah, my concern there is that sometimes that works out well and sometimes it's a disaster. Why is it sometimes a disaster? Because we have about 1 in 3 of our patients that just don't do well with upper cervical chiropractic. So that's the concern. If you happen to be in that 1 in 3 and you're trying it after the fact, then you could end up worse. So that's always been my concern, is it's hit or miss after. And that's why I'll continue to advise people to try that before a PICL. If you're in the responder category, then play right through and continue to get it. But don't add it in after, because if you turn out to be in that 1 in 3 that it just doesn't work for, or it aggravates things, then that's a bad day for everyone. At dogs repeat. I have all symptoms of CCI. The team of people here in Virginia say none of CCI is proven in literature. I have red arms and pain in my neck, off balance, CME, and numerous other weird things. Yeah, so the best thing you could do is to get with a provider who has experience in CCI. If you're in that DC metro area, that's where Dr. Henderson is. He's right there in Maryland. So I'd probably try to get in and see him because he understands how to make that diagnosis. There are norms in the literature for how much movement you're supposed to have. So I would imagine those doctors don't really understand that. But I think Dr. Henderson is right in your area. So I think that's an opportunity to be able to drive to somebody who is a CCI expert. PIA, which structures need to be treated with an unstable shoulder? Is capsule hard to treat? Capsule is not hard to treat. So normally it is that shoulder capsule that's treated for an unstable shoulder. Dogs repeat. My x-ray with flexion extension was normal. So they said movement-based x-ray, something MRI. We'll tell them nothing else. I'm so frustrated. I don't know what to do. Yeah, so again, upright MRI can show things that a flexion extension x-ray can't, and you have Dr. Henderson right in the neighborhood there, so that's what I would do if I were you. Veronica, when do you consider Eagle syndrome as part of the issue? Could it be CCI, AI, and Eagle syndrome? Yeah, Veronica, you're on Facebook, but if you go to the YouTube channel and just look up Eagle syndrome, you're going to see lots of videos I have on that subject that'll dive deeply into all of that. Alexis, will cervical stabilizing muscles shut down as a result of pain? They will, absolutely. Pia, which ligaments of the knee can be reached? If I assume behind the patella is not possible. Pretty much all of the ligaments in the knee can be reached: ACL, PCL, ALL, MCL, LCL, they can all be reached. Can an active dental infection cause flares with CCI symptoms, and what's the best course of treatment for a dental infection? 6 weeks after PICL? Yeah, I think if you've got any sort of other infection in other parts of your body, that's going to raise systemic inflammation. So that's going to cause a flare up of pretty much everything, including CCI. And the best course of treatment for any infection, obviously, is to get the infection taken care of. And that's usually oral antibiotics. So I would definitely work with your dentist on that. Ashley, I got off my antidepressant for my EPICL. I'm getting back on it. Would you recommend getting off it again for the next EPICL? Wouldn't want to do anything to affect anesthesia, since I also found out during EPICL that I might have mild sleep apnea because it started to desaturate when they put me face down. Yeah, so I think what you're bringing up, Ashley, is important, and that is certain medications can impact how much anesthesia you need to stay asleep during any procedure, including the EPICL procedure. And so that's why we generally tell people to get off those things. Having said that, you also have to weigh that with the doctor who is prescribing that antidepressant, right? There may be no-goes where they say, listen, I don't want you stopping this because of X, Y, and Z, and we'll have to accept a slightly elevated anesthesia risk. I would agree with you that if you already have obstructive sleep apnea or mechanical apnea, and that was evidenced during the procedure, then probably better to be on fewer medications than more. But those are things that's always best to discuss with the doctor that prescribed that medication. Let's see here. I'm going to try to just answer one or two more here. Steve-O Wrestler, 12 weeks back training Muay Thai after a few years layoff while caring for my mom. Knee feels great. Bag work, pad work, pivoting to kick, no issues and full power. Well, great to hear, Steve. Thanks for that update. And then finally, last question of the day, can CCI cause TMJ symptoms? It can. That's pretty common in our CCI patients. I would say about 1 in 3 to 1 in 4 of our CCI patients have TMJ as a result of their CCI. Okay, guys, great hour. Lots of great questions. There are no bad questions. And it's great to see lots of questions here because that's how many patients learn, right? They hear a question and like, oh, that applies to me. So thanks so much for joining me. I will be back next week as well. And I'll be here throughout the summer until I go on my fall sabbatical. So we'll be doing one of these every week, trying to answer your questions. And at the same time, trying to come up with an interesting topic. If you're interested in trying to shape the questions that I ask or the people I interview, just go ahead and get on that Reddit thread. That's RPICL on Reddit. And there you can say, hey, doc, if you thought about this topic, because I'm always looking for a topic, right? Sometimes the topic is clear because of what's being discussed out there on the Reddit sub. And sometimes it's less clear as to what I should talk about that people will be interested in. So go there to submit your suggestions. Thanks so much for watching. Have a great rest of your weekend, and I will see you back next week. Thank you.